So moving on to our second speaker and our second lecture of today, which will focus on ECGs. We have Dr. Mohammad Fakhraldeen with us, who works in emergency medicine. He did his emergency medicine residency in McGill University. He works in Sabah Hospital in the emergency department. He's the chairman of the emergency department. He's an emergency physician and clinical site coordinator. He also is a member of the Kuwaiti Board of Emergency Medicine, and he's a faculty member there, a clinical tutor, and also a committee member in the Emergency Medicine Board. Welcome, Dr. Mohammed, and the mic is yours.
Assalamu alaikum. Good afternoon, everybody. Thank you, Yusuf, for that introduction. I'd like to thank Dr. Mariam for the very interesting talk. Actually, just yesterday I saw a very interesting case of a rule-out Stevens-Johnson syndrome. So without further ado, I'll go ahead. ECG is a huge topic, and I'll touch a bit upon the reflections that made me decide what to focus on, what I believe to be the most important specific aspects of the ECG. I called this an enticing escapade because I find it reading ECGs in the clinical context fun, enjoyable. There's a lot of learning to be had. No matter how much I learn, there's always more to learn, and every ECG is different than the preceding one. It's an adventure. I'm always revisiting, reinforcing old knowledge and building new knowledge on top. It may be elusive because ECGs can be very challenging in the clinical context, which is part of why what makes them fun. So thank you for joining me on this journey, and inshallah you'll be able to take something home from this talk as I did from preparing it. I have no conflicts of interest to disclose. I love to learn, I love to teach, and I really value the bedside clinical interaction, and I hope you do too. So just a quick outline of the talk. I'll comment quickly on the learning environment. This is obviously a virtual learning platform. I'll go through the objectives, and then how I went about selecting the material for the talk. In terms of the bulk of the talk, the main material, I'll focus on the machine, the connections, and the patient. So the machine, I'll touch upon adequate versus inadequate calibration, speed and voltage very quickly because they can significantly affect the way we look at our ECGs, and they can lead to dangerous, sometimes misdiagnoses. The connections lead misplacement and consequences thereof for the same reasons. In terms of the clinical aspects, I decided to focus on the ECG in suspected acute coronary syndromes. We'll go quickly through STEMI, the use of the modified Scarbosa criteria in left bundle branch block ECGs to identify myocardial infarction, and then some very important STEMI equivalents. Then we'll go into the second major component, which is the ECG in pre-syncope/syncope. We'll quickly define syncope to make sure we're on the same ground, an approach to the ECG in syncope, and then some ECG findings in certain clinical syncope syndromes. I'll then summarize, highlight some take-home points, put up my references. Okay, so just a second disclaimer. This talk is not comprehensive. It is concise and targeted, practical and clinically relevant, and hopefully both exam-oriented for you guys as well as learner-oriented. After asking around, I've prepared this talk on the premise that the attendees have ECG basics down. So while we will go over some basics as they come up throughout the talk, I would like to focus on very specific practical and clinical aspects. I hope this will be more conducive to knowledge acquisition and retention. So this is a safe learning environment. I'd like to thank you all very much for this learning opportunity for myself, as well as the teaching opportunity. This is not a lecture. This is a safe platform for knowledge sharing and hopefully a discussion to an extent I appreciate that it's limited because of this virtual platform. So just quickly about the material selection, I received a lot of information from the session moderator, Dr. Yusuf Nurmiah, so I thank him for that. He supplied me with your curriculum guide, so I referenced back to that while preparing for this talk. I also spoke to recent family medicine graduates on certain aspects that they thought they would have liked to have had exposure to during their training. In addition to speaking to some emergency department colleagues, because we are on the receiving end of a lot of patient transfers. So I extrapolated, I based the material after going through this process. I just wanted to highlight that. So in terms of the objectives, trying to be specific now, when we're talking about the machine, I hope that the learner will know standard ECG calibration, speed and voltage. This is in no way, shape, or form rocket science. I'm not a physicist. I try to keep things very simple for myself and very practical. It's just a couple of quick things to check to make sure the ECG you're looking at is adequate for interpretation. In terms of the connections, it's also related to the previous point to an extent, making sure you don't have lead misplacement and to recognize the most common incorrect lead placement on the ECG that we see. In terms of the ECG and suspected acute coronary syndromes, I expect the learner to define STEMI ECG criteria according to the most recent ACC, American College of Cardiology, and American Heart Association guidelines from 2022, in addition to defining the territories based on the ECG leads involved. Also, I would like for the learner to apply modified Scarbosa criteria to ECGs with left bundle branch block. And I highly recommend for any kind of clinical rules or even things like this Scarbosa criteria to use an app like the MD Calc app or any other app that you can get for free on the App Store, because there's some rules have a lot of detail that you'll never memorize off the bat, but that will stick with practice and with repetition. And then I'd like to the learner to consider STEMI equivalence. So they don't see a rip-roaring STEMI on the ECG, but the clinical context is concerning, and we all know the clinical context is the most important thing, to consider things like Wellens syndrome, the winter T waves, posterior MI, AVR, ST elevation. I appreciate there are more STEMI equivalents, but I had to kind of pick and choose because of the limited time frame. And then the final list of objectives, the ECG and pre-syncope/syncope. So I feel it's very important for the learner to define syncope very simply, but very clearly. Also to adopt an approach to the ECG and syncope. So what to specifically look at an ECG and syncope. And then after that, to recognize specific clinical syndromes based on specific ECG findings. So things that can predispose to syncope, including symptomatic bradycardia, ventricular pre-excitation, what we all know as Wolff-Parkinson-White, the Brugada syndrome, long QT syndrome, and hypertrophic obstructive cardiomyopathy. So having gone through the introduction, specifically the objectives, we'll jump into the material now. So in terms of the machine, so standard US UK calibration, which is what most, if not all people here in Kuwait use, is a voltage of 10 millivolts per millimeter and a speed of 25 millimeters per second. So just quickly remembering that each small box is 40 milliseconds on the ECG, each large box is 200 milliseconds. So if you look at the bottom of the screen, and you should have this on all your ECGs, you should have the speed and the voltage. So if you don't see those numbers, there's something wrong. And it's like sometimes some machines are very sensitive. It's just a button that anybody can accidentally knock, and that may alter the speed and or the voltage. So you need to verify that with your ECG technician or the nurse who's in charge of performing the ECGs. So the way you check that on a real ECG is you look at the rectangular shape at the far left that I've circled in red. The amplitude, so the height should be two large boxes and the width should be one large box. And then I've placed a kind of an oval shape at the bottom. That's where you check the speed and the voltage as well. So you've got those two things to check on any ECG before you even consider starting to interpret them. Now, there are a lot of other things that you can adjust that are beyond the scope of this talk, things like the frequency that may help with baseline artifact, but the trade-off will be a change in the morphology. So really, these are the two key things that you need to check. So the image on your left is a marker of a well-calibrated ECG as opposed to the image on the right, which is not. So just to quickly give some examples of how poorly calibrated or inadequately calibrated ECGs can affect the interpretation. You can appreciate the significant voltages that you see through most leads, specifically 2, 3, V1 through V6. Those are sizable complexes. The amplitude is very generous. But if you look at the far left, the rectangle is also very generous in height. It's approximately four large boxes. So it's beyond the 2 that we expect to see. So that's too much voltage, not enough voltage. So too much voltage, you're thinking LVH, you're thinking maybe HOCM, you're thinking of a specific list of diagnoses, but these would be false positives because of the high voltage. Now, if you have inadequate voltage, then you have very small amplitude QRS complexes. And you'd go down the rabbit hole of considering things like pericarditis, etc. But you really need to ensure that the ECG is well calibrated. If you look at the rectangle at the far left, the height is only one large box. Now, going into the speed. Now, the speed of this paper is too slow. If you look at the bottom, it's 12.5 millimeters per second. Okay, so what does that mean? That gives you a false tachycardia. The way that happens is that the ECG paper moves through the ECG machine at a slower pace. So since it's moving slower, the QRS complexes will be printed closer together. So it'll give you a false tachycardia. And the opposite happens when the speed is too fast. When the ECG machine is moving too fast, you'll have a false bradycardia. So just remember those two things in terms of the machine, the voltage and the speed. And we'll summarize at the end as well, just to remind everybody. So the connections, we've all seen Einthoven's triangle. This is just a quick visual reminder. One of the most common lead misplacements we see is the right and left arm leads misplacement. So they get switched with each other. A quick screen for normal lead placement is to look at the P wave. So leads 1 and V6 are looking at the ECG from the same direction, at the heart, sorry, from the same direction. So both should have upright P waves, as opposed to lead AVR, which should have a downward P wave. The exception is if you have an ectopic source of the impulse, but that's an exception. So in general, P wave should be up in leads 1 and V6, down in AVR. If this is not what you're seeing on your ECG, then seriously consider lead misplacement and go back to your ECG technician and or nurse who are conducting the ECG, performing the ECG, and make sure that the leads are well placed so you can adequately interpret the ECG. So just try to apply that on this ECG. So 1 and V6 should have upright P waves. So if you look at lead 1, there is some baseline artifact that's affecting your interpretation, but it's almost biphasic, but it's mostly downward in lead 1. Whereas you look at V6, the P wave is upright, definitely upright in V6. And then if you look at AVR, where the P wave should be down, again, it's not entirely clear on these ECG, but it is upgoing. So these findings are definitely concerning for lead misplacement. Okay, and then so if you ignore the P waves and just look at the ECG, then you might be worried about kind of ischemic changes because you have almost deep T wave inversions in leads 1 and AVL, which may make you concerned about something going on in the lateral territory. So I've highlighted those here. And then the corrected ECG is this one. So essentially it was an ABR, it was a right atrial, right arm, left arm switch. So that's the corrected ECG. So just another example. So if you look at lead one, again, the P wave is kind of biphasic. If you look at V6, the P wave is definitely upright. And in AVR, the P wave is upright as well. Okay. So forget about the P waves and look at the rest of the ECG. You definitely be concerned about kind of a diffuse ST elevation picture, almost diffuse multi-lead ST elevation, which may kind of drive you down the route of possible pericarditis. However, when you correct, when you adjust the lead placement and place them correctly, then you're actually dealing with more territorial ECG changes and something more concerning for a territorial myocardial infarction. So with that, we've gone through voltage, speed, and leads. So discuss the machine, the connections. Now we're going to jump into the patient. Okay, so I like to keep the talks I give case-based. I also love for them to be interactive, but again, I appreciate that's going to be limited in this platform. So start off with our first case, 55-year-old male, diabetic, hypertensive, chest pain for 2 hours, anterior radiating to the left arm, nausea, vomited once. Okay, I suppose one of the most important questions to ask is, when should we perform the ECG? How soon after first medical contact does the AHA/ACC, American College of Cardiology, recommend a 12-lead ECG be acquired and interpreted? So is it 10, 30, 60 minutes, or no specific recommendation? So just think about that for maybe 10 seconds, and then we'll move on. Okay, so I suppose most people know this. The answer is A, it is 10 minutes. So in real life, it really should be done as soon as possible. But the idea of setting a maximal time limit is to make sure people don't go beyond that, but really as soon as possible. Okay, so what are the ECG ST elevation criteria? Are we looking for at least 2 millimeters in all leads or at least 1 in all leads, or the same with the exceptions of V2 and V3? So just think about that for 10 seconds before I reveal the answer. So the answer is D. These are the criteria: new or presumed new ST elevation at the J point, and we'll bring up an image of that soon. In at least 2 contiguous leads, it has to be at least 1 millimeter in all leads except in V2 and V3. And you can see it's different between females and males, and also between males 40 years and above or males under 40. The easy way to remember that is in the progression that I've outlined here in the slide from top down. You can see the required amplitude of ST elevation goes up as you move from female to males over 40 to males under 40. So the younger males need more ST elevation than the older males than the females. And again, the way to make, if you're not in the business of looking, so in the emergency department, we're looking at tens of ECGs each shift. So we get exposed to a lot of ECGs. I appreciate that it's different in your context, but the way to make these things stick is just continuous and longitudinal exposure, and just keep looking these things up until they stick. Also stay updated, guidelines change, and I'll touch a bit upon that soon. So before I pop up the graphic image, this is just one last question. So what's the baseline ECG segment that you use to compare the J point to when you're determining whether there's ST elevation or depression? So is it the PR or the TP? And is it the preceding, so the segment that's before the relevant ST? Or is it the succeeding, the subsequent the one after the ST. So just think about that for maybe 5 more seconds. So it actually is the subsequent TP segment, and you'll find some references that quote otherwise. But in the research that I've done in preparing for this talk, as far as I'm concerned, it is the subsequent TP segment. So if you look at this here, so we spoke about the J point, and you can see it right there. It is the junction between the end of it is the end of the QRS complex and the beginning of the ST segment. So it's that junction where you determine elevation versus depression, and you compare it to the subsequent TP segment. So that's the kind of burgundy colored / red colored box, the TP interval on this image. This is a very useful visual reminder of the territories. Again, if you don't get exposed to this a lot, just take a screenshot, and that's the reference right there, Rebel-EM. It's a great website that has a lot of things, but this is what I took this from that website. So again, this is the kind of thing you need longitudinal exposure to help make it stick. So just remember our patient, the 55-year-old guy, diabetic hypertensive, chest pain for 2 hours. This is that patient's ECG. So just look at the ECG for maybe 10 seconds. Try to identify any abnormalities and to determine the nature of the abnormalities based on the leads involved. So you can see there's ST elevation with hyperacute T waves in leads V2 to V4. So the T waves are quite significantly elevated, and there's definitely ST elevation if you look at the J point in those leads. You also have more subtle ST elevation in leads 1 and AVL with reciprocal ST depression in lead 3. You can see that in lead 3. In addition, you have Q waves in leads V1, V2, which are the septal leads. So all of these features put together are indicative of a hyperacute anterolateral MI. Okay, so our second case is a 60-year-old male who's hypertensive, chest pain for 1 hour, radiating to their right arm and sweating. And actually, I'll just take this opportunity to put in a clinical plug. It is specific to the patients with chest pain who present to the emergency department, you may consider extrapolating it to an extent, because a lot of the patients we receive are actually transfers from primary care. We also receive a lot of patients from home, etc., from the workplace. So the clinical plug is the fact that in ED patients presenting with chest pain, there are a few factors that are associated with higher morbidity for those patients. Now, 2 of those factors are mentioned on this slide. One of them is sweating. One of them is nausea, vomiting. One of them is an exertional nature to the chest pain. And then the last one is radiation. So we're classically taught that radiation, ask about radiation to the left arm, to the left shoulder, etc. It's actually been found that radiation, so any radiation is associated with higher morbidity for the patient, but radiation to the bilaterally is worse than radiation to the right, is worse than radiation to the left. So it's that kind of order. But in general, any radiation is concerning. So those 4 factors, again, are sweating, radiation, nausea, vomiting, and an exertional component to the chest pain. So this guy's ECG is here, and unfortunately, I couldn't remove that circle, but just have a look at that for about 10 seconds. So what's striking about this ECG is a specific morphology. So the morphology here is that of a left bundle branch block. And this is where it can get tricky. So I'll touch upon this soon in the next few slides, but essentially the left bundle branch block criterion in and of itself for cath lab activation or a new left bundle branch block has been removed because only 2 to 4% of those patients have been found to have occlusive lesions. But in terms of looking at an ECG with a pre-existing left bundle, how do you determine whether or not you should, consult cardiology, activate the cath lab, call an ambulance to shift the patient straight from your primary care center to the emergency department? So there are very well validated criteria called the modified Scarbosa criteria. So what we see on these, and I'll put up an infographic soon, but what we're looking at, what we're finding on this ECG is that we have 1 millimeter ST elevation in lead ABL, which is circled right there, in addition to 1 millimeter ST depression in leads V5. It's very obvious on this ECG. In addition to lead 3, plus minus AVF. Okay, so if you look at the ST elevation, if you look at the QRS complex that's circled in ABL, it is predominantly positive. Most of the complex is above the isoelectric line, and there's ST elevation. So what we call that is we call it the ST elevation concordant with the we call it concordant ST elevation because the complex is predominantly positive and you have ST elevation. In addition, in lead 3, you see ST depression and the complex is predominantly negative. Most of the complex is below the isoelectric line. So we call that concordant ST depression. And these are important components of the modified Scarbosa rule. So I've circled those there. So this is the modified Scarbosa. Again, pull up MD Calc. Just at any time you look at an ECG with a left bundle in a patient on whom you're considering an acute coronary syndrome, just pull it up on MD Calc and just apply it until it sticks. In general, you're looking for concordant ST elevation, at least 1 millimeter. You're looking for concordant ST depression, at least 1 millimeter. Or you're looking for discordant, so that's the middle image on this slide. Number 3, you're looking for discordant ST elevation. So that's where you have ST elevation on a predominantly negative QRS complex. So if any one of these 3 are present on an ECG with the left bundle branch block in a patient on whom you're suspecting acute coronary syndrome, then the patient screens positive based on this rule. And this rule, as you can see on the screen, bottom right, it's 80% sensitive and it's 99% specific for an acute coronary syndrome. So it's very useful. So the specific component of the rule is the discordant ST elevation. It has to be at least more than 25% of the height of the S wave. So again, it's just something you need to train your eye on, and you just need to, pull up the rule every time until it sticks. It was obvious on the ECG that we just highlighted. So now we're just going to go into some STEMI equivalents. Okay, so case 3, you got 70-year-old male who's diabetic, comes in with a half-hour history of chest heaviness that's retrosternal and exertional. This is that patient's ECG. Okay, so what's striking about this ECG? I suppose the most striking feature is the T-wave derangements, namely in leads V2 to V6. You can see they're biphasic in leads V2, V3, but predominantly going down, and definitely down going in V4 and V5. So when you look at the T waves going deep down, like they're going into a well, so think of Wellens syndrome. So Wellens syndrome, this is the classic appearance of Wellens syndrome. You on an ECG, you've got a couple of different types. One where on the left side, type A, where the T waves are a bit more biphasic, and then type B, where you have deep symmetrical T waves. So this signifies a severe proximal LAD lesion, the left anterior descending lesion. So the presence of Wellens wave with a history of chest pain, And a troponin that's either normal or minimally elevated has an 86% positive predictive value for an LAD lesion. So this is a very important STEMI equivalent to identify. Next case. So we've got a 50-year-old female who's dyslipidemic, comes in with retrosternal exertional chest pain and nausea. This is that lady's ECG. So what's one of the most striking features of this ECG? So you've got some ST depressions in addition to tall T waves. So most common precordially in leads V2 to V4, 5, also extending to V6. In addition, you've got ST elevation, 0.5 millimeter to 1 millimeter of ST elevation in AVR. So we call these the winter T waves. So the way I remember that is, I remember snow on top of on mountain peaks in winter. So you've got peak T waves, so the winter T waves. It's a bit of a lame attempt at remembering them, but that's how I remember them. And that's how I differentiate Wellens from the winters. Essentially, both of them are STEMI equivalents, and both of them really should prompt. If you don't have direct access to cath lab activation, they should prompt definitely cardiology consultation. A patient with in whom with whom you're concerned, if your concerned patient has ACS and you're seeing this kind of ECG, this patient should be put on the back of an ambulance and sent immediately to the emergency department. So this is also indicative of a proximal LAD occlusion. So case 5, you've got a 55-year-old diabetic female who comes in with anterior chest pain radiating to the back and the patient's sweating. This is that patient's ECG. So what's the most striking thing on this ECG? You can see it in leads V2 through V5, plus mine, and V6 as well. Primarily V2 to V4, 5. So you're seeing ST depression. So what's the next thing you're going to order? The next investigation you're going to order is posterior lead ECG. So one trick that we're always taught is to invert the ECG. So if you're holding it like this, just kind of invert it up and look at it under the lights, and what was ST depression will appear like as ST elevation, but you really need to get the posterior leads. So V4, 5, 6 become V7, 8, 9 as you see here. And then you appreciate the posterior ST elevation that causes reciprocal anterior ST depression. So keep posterior MI on your differential in these patients. So our last ACS case is a 65-year-old female who's hypertensive, who comes in with chest pain. That's anterior radiating to left arm, nausea, vomiting ×2. So what are we looking at here? I've circled one of the findings, which is ST elevation AVR. In and of itself, it's definitely concerning. AVR and V1 are the two leads that look at the right ventricle most directly. But the associated concerning findings are diffuse ST depression. So you've got AVR ST elevation and diffuse ST depressions in the right clinical context, and maybe one of three things: a left main coronary artery occlusion, proximal LAD, or even triple vessel disease. So this is a disaster until proven otherwise. So I know it's quite a roller coaster looking at these images, not being able to interact in a kind of a workshop fashion. But I tried to pick the most relevant ACS cases based on the research that I've done with your program requirements, and also consulting family medicine and emergency medicine colleagues. So hopefully you found that useful. Now we'll go into the second major component of our talk, which is the ECG and syncope, presyncope. We both see a lot of this. You see a lot of this in primary care. We see a lot of this in the emergency department. We see a lot of pre-syncope and syncope. The ECG is a very cheap test. It should be performed on all patients who present with syncope. And there are specific things that we need to look for on these ECGs. So we'll start off, like I said earlier, by defining syncope. So there are some key terms, whenever you consider syncope, there are some key terms that you need to check off to make sure whether or not you're dealing with syncope. Now, a lot of times you don't have access to that information. And you don't have a witness, the patient was on their own, etc. So you may not have a complete picture, but whenever possible, try to complete the picture. So really what syncope is a sudden transient loss of consciousness with loss of postural tone. Some people who define it also add the component of spontaneous resolution. But essentially, these components need to be checked off to clinch the diagnosis, the clinical diagnosis of syncope when possible. Now, when we're looking at the ECG in syncope, pre-syncope, we need to make sure there are no signs of ischemia. Ischemia does not commonly present with syncope, but it may, and I'll touch a bit upon that in a few slides. We also need to look for signs of brady or tachydysrhythmias. And one of the most important components of the interpretation of an ECG in a patient with pre-syncope, syncope is to look at the intervals. So I've put on the slide the reference ranges. The PR ranges from 120 to 200 milliseconds. QRS, I've seen the 100 milliseconds in some sources, 110 milliseconds in others. The corrected QT, as you can see, should be less than 460 in females, less than 440 in males. So you really need to make sure you check the intervals. So screen for ischemia, look for bradys, tachys, and then check the intervals. Okay, so in terms of clinical presentations and specific things to look for, these are the ones that we'll cover as I highlighted earlier, and we'll jump into our first case. So the first case is a 68-year-old female hypertensive on diltiazem who presents with a history of syncope. She's been complaining of progressive dizziness for the last 2 days. Her heart rate is 35, but the exam is otherwise normal, the rest of the exam. And this is what you see on the rhythm strip at the top and the ECG at the bottom. So just looking at the ECG, definitely the most striking thing is the heart rate. There are no clear signs of ischemia. We're not seeing any evidence of any syncopal syndromes that we can detect on ECG. So this is a case of symptomatic bradycardia in a patient who is on diltiazem for high blood pressure. Bradycardia is secondary to chronic conduction system disease, exacerbated by a calcium channel blocker. The patient ended up getting a right ventricular permanent pacemaker. So this is a useful segue into ECG heart rate calculation methods. There are a few different methods. These are the three main ones. No specific one is better than the other. Preference varies between physicians. There are certain methods that may be better for certain rhythms, bradys, tachys. And for example, if you've got an irregular heart rate, like if you've got a case of atrial fibrillation, then you would not be able to get an accurate heart rate using the first two methods, but you get a more accurate heart rate using the last method. And I'll put up some infographics right now. This is just a quick reminder of the timings and the intervals. Each small box is 40 milliseconds. Each large box, which is 5 small boxes, is 200 milliseconds. And remember, always make sure that the ECG is well calibrated. You're looking at that rectangle at the far left of the rhythm strip. You're also looking at the bottom, looking at the speed, 25, the voltage, 10. So just remember those things. So this is one of the most common methods, most popular methods from what I've seen. Just divide 300 by the number of large squares between consecutive RR intervals. This is another method. It's essentially the same, but you're just dividing 1500 by number of small squares between consecutive RR intervals. Okay, and then this is the last method, which is where you take the rhythm strip at the bottom, so that's lead 2, and then you count the number of R waves you see, and then you multiply that by 6. So you've got 9 R waves here. So 9 times 6 is 54. And you can see, so that's at the bottom right. You can see at the bottom left and the bottom center, they use the other calculation methods as well. Again, this is most useful for irregular rates, irregular rhythms. So we'll move on to our second case. So 24-year-old male, healthy, had a pre-syncopal episode associated with sweating. Has a heart rate of 200, a systolic of 70. You see this on the monitor. You've obviously already called the ambulance, but they're on their way. You diagnose what obviously is VTAC, and the patient is currently, alert oriented. So you perform a synchronized cardioversion with 100 joules. Patient regains normal sinus rhythm. The ambulance still hasn't arrived. The patient has a full-blown syncopal episode, but pulse is present. Patient breathing spontaneously. Again, VTAC. You do a repeat synchronized cardioversion with 150 joules. You regain normal sinus rhythm. Patient's awake, stable, normal vital signs except a mild tachycardia of 110. Ambulance on the way. What's your next investigation? It's obviously going to be, make sure the patient's stable. Your next investigation is your 12-lead ECG. So what's peculiar about this 12-lead ECG? There's something very peculiar about the beginnings of the QRS complexes, the ones with the positive deflection, the ones that are predominantly positive. So this is a case of ventricular pre-excitation, Wolff, Parkinson, White. This is a patient has an accessory pathway with anterograde conduction, and the definitive treatment is ablation. The acute treatment, the agent of choice is procainamide. There's a triad on the ECG. The short PR, and you progress from left to right, the short PR, and there's a wide QRS, and there's an associated delta wave. That's part of the wide QRS. So the second and the third point make sense together. You may see Q waves, T waves. These are what they call pseudo-ischemic changes, and they do not signify an acute coronary syndrome. You take everything in the clinical context. If the patient's symptoms resolve after they stabilize, etc., you take everything in the clinical context. And I appreciate I'm not touching a lot on the management. Again, that's because of the specific objectives that I delineated at the beginning. So this is the triad visually. So again, you have a short PR moving from left to right. You've got a short PR interval. You've got a delta wave, which is that slurred upslope of the QRS, and then you've got a wide QRS. Okay, you may or may not have the pseudo-ischemic changes that we spoke about earlier, like the inverted T wave. Okay, so what's the significance of Wolff, Parkinson, White? This puts the patient at risk of tachydysrhythmias, whether they be supraventricular, like paroxysmal, SVT, AFib, aflutter, or VFib, or even sudden cardiac death. And we see a lot of that in young athletes. This is why some countries have national screening programs for athletes. Okay, case 3, a 38-year-old male, healthy, presents with a syncopal episode preceded by severe lightheadedness for 3 hours. Normal exam. So what are we looking at here? So if you notice the RS, R prime pattern in leads V1, more so V2, V3, that's indicative of a right bundle branch block. We call it incomplete because despite the morphology, it's a narrow QRS. It's not a wide QRS. So in addition, with that, you have coved, what we call coved, in the sense that they're concave up ST elevations, kind of like you can draw a smiley face on the ST segments, namely in leads V2 and V3. So this is Brugada syndrome. Brugada syndrome is a sodium channelopathy, and there are different types, but the details of which are beyond the scope of this talk. But essentially, you have an incomplete red bundle and you have anterior ST elevations, namely V1 to V3, and the patients are at risk for VF in addition to sudden cardiac death. The treatment ultimately is an ICD, and these patients need follow-up. So, case 4, we're almost done, and hopefully we're on time. So case 4, 12-year-old male, healthy. His paternal uncle had suffered sudden unexplained death as a teenager. Patient himself is healthy, suffered a syncopal episode, had a normal exam. This is that patient's ECG. So if I were to ask you to focus on something, on specific leads where the abnormality is quite prominent, it would be leads V2 and V3, V1 as well. So the QT is very generous on this ECG. It's very prolonged. There's a specific way to calculate it. There's also a quick visual method we'll go through. So this patient has long QT syndrome. They need to be, especially if they have, these patients are picked up after they suffer symptoms like, or have a screening ECG. So if they've had a syncopal episode, they need, or if it was picked up on screening, they need to be seen by cardiology. They may or may not need medications like metoprolol, etc., plus minus family screening, their siblings, etc. So where does the QT interval begin and end? The QT interval begins from the beginning of the Q wave to the end of the T wave, and that's this two-headed arrow you see here. So that's your QT interval measured on the ECG. You need to calculate it, and I'll put the equation soon. But to visually estimate it, just roughly look at the ECG. If the QT interval is more than half the RR interval, which is that second two-headed arrow up top. If the bottom arrow is more than half the top arrow, then the patient most likely has a prolonged QT interval, and there's a huge differential for that. Obviously, in younger patients who aren't taking medications or drugs or anything like that, you suspect it to be congenital, but that discussion is beyond the scope of this talk. We're primarily aiming to identify it. So this is the equation you use to calculate the corrected QT. Again, if you forget it, just pull it up on MD Calc. It's the measured QT divided by the square root of the RR interval. So what essentially does, it prolongs the ventricular repolarization and puts the patient at risk for polymorphic VTAC and even sudden cardiac death. And those are the cutoffs for long QT based on gender. Okay, so our last case. 31-year-old female presents with a syncopal episode, negative personal past medical history, negative family history, negative drug history, normal exam. And this is that patient's ECG. So there's something that's extremely striking about the ECG. We're going to look at the rectangle at the far left to make sure the ECG is well calibrated, the voltages are normal. We're going to look at the speed, which we should have printed at the bottom. We don't on this ECG. So what we're seeing are extremely high voltage QRS complexes in leads V2 to V6. We're also seeing what some people call dagger Q waves or deep Q waves in leads V4 and more so in V5 and V6. So this is a case of hypertrophic obstructive cardiomyopathy. They need to be formally diagnosed by having a transthoracic echo. They may or may not need to be admitted, or they may be followed as an outpatient, depending on the clinical situation, the clinical circumstances, how secure the follow-up is, etc. And they may benefit from things like metoprolol, etc., after consultation with a cardiologist. So in terms of the ECG and HOCM, it's abnormal in 90% of cases. However, most of the abnormalities are non-specific. You may have some Q waves, you may have a QRS that's of high amplitude or prolonged duration, or some STT wave changes. The most common ECG abnormality is a large amplitude QRS, which we saw, and the most specific one are deep, narrow Q waves in lateral leads. So what's a deep Q wave? It's a Q wave that's more than two small boxes in amplitude. And finally, on this case, before we summarize, there are some age-specific HOCM findings, HOCM, hypertrophic obstructive cardiomyopathy, that you can see. You can just take a snapshot of this slide. As you can see, the findings specific to the teens have extremely high, 100% specificity and positive predictive values. I would just caution that, things that stand true in a given patient population may not necessarily be extrapolated to another patient population. So, wherever they got these numbers from, wherever that study was done, definitely wasn't in Kuwait. So just be mindful of that before you decide to extrapolate the findings of a study to your patient population. So thank you for bearing with me. I'm just going to summarize. So we went through calibration, looking at the machine itself, making sure that the voltage is 10 millivolts per millimeter. We're going to read that at the bottom of the ECG, 25 millimeters per second. That's the speed we're going to read at the bottom. We're also going to verify those by looking at the rectangle at the far left, making sure it's like the rectangle on the left-hand side at the top of the slide there. 2 large boxes in height, 1 large box in width. Some people even say it should be really perfect 90-degree angles. Some rectangles aren't. That may mean that it's not well calibrated. We're going to look at the P waves to make sure that there are no signs of lead misplacements. Specifically, the P wave should be up in leads 1 and B6, down in ABR. The ACS ECG, we went over the AHA-ACC STEMI criteria. How to diagnose STEMI in a left bundle. Now, I just forgot to say, some people apply the modified Scarbosa criteria also to paced ECGs, so ECGs done on patients with pacemakers. And I've seen that widely adopted. However, I haven't seen validated evidence for that, or strong evidence for that. If anybody has any, please share it. But it's definitely been validated in left bundle. Semi-equivalence, we went through them. So remember, Wellens, like a well, so looking at deep T waves, the winter, so mountain peaks, snow on mountain peaks in winter, so peak T waves. Posterior MI, so you have anterior ST elevations, flip the ECG. Remember to do your B7, 8, 9 posterior leads. AVR ST elevation, especially if it's associated with diffuse ST depressions, very concerning, left main, LAD, or even triple vessel disease. The syncope, pre-syncope ECG, remember definition of syncope, the components. Approach to the ECG and syncope, make sure it's not ischemia. Ischemia, like I said, it's quite, ischemia rarely presents with syncope, but we can see that in elderly patients with atypical presentations, or if the RCA is involved, affecting the AV node, causing heart block, causing syncope. So that's another differential for syncope, is heart block. Tachycardia, bradycardia, conduction delays, remember your intervals. Specific clinical syndromes and their ECG findings. So we looked at symptomatic bradycardia, Wolff, Parkinson, White, Brugada, long QT, and HOCM. Finally, last slide, take-home points. The clinical picture is paramount. It is key. Always ask yourself why you're doing the ECG. What's the indication? There's something called indication creep, doing investigations unnecessarily, picking up incidentalomas. There's an excellent paper on overdiagnosis. Overdiagnosis is a very dangerous entity. Patients may live a healthy life and die of a different reason, but have to undergo a lot of harmful testing because of incidental finding that was unnecessarily detected. So just be very careful about anything you do, and have a clear algorithm to deal with the findings of your test. Always ask yourself, if this is the result of this test, I'm going to do that. If that's the result, I'm going to do the other thing. So always have a very clear algorithm. ACS rarely presents with isolated syncope. I mentioned that. So the last thing I want to talk about is lifelong learning. This is one of those things. ECG, X-ray, a lot, chest X-ray, a lot of these things. You need longitudinal exposure. It has to be systematic. I highly recommend website, the Life in the Fast Lane website. They've got an excellent ECG library with small clinical vignettes. I went through an ECG a day, 100, 150 ECGs. I'm planning on going through them again. They also have a nice chest X-ray library. Keep an eye out for updates. There's a new occlusion MI versus non-occlusion MI. It's not widely adopted. It hasn't been validated yet. But this, if it does get adopted, then it's going to significantly change the way we deal with our ACS patients. Medicine will always remain a scientific art and not a pure science. So make sure you have make sure you're always open to changing whatever you've learned and always asking questions. And I just like to once again thank you all for allowing this opportunity to share this knowledge. I've learned a lot. I hope you have too. Thank you. Special thanks to Dr. Ma'atar Zaid. I just remembered she's a PGY2 resident in our Kuwait Board of Emergency Medicine. She's an ECG whiz. She authored an ECG book during med school. She shared a lot of ECGs with me. She also brainstormed some important topics. So thanks to her and thank you.
Thank you very much, Dr. Mohammed, for the very informative lecture. We learned a lot, and I agree with the point you raised that it's a challenge in primary care is that we're not seeing the amount of ECGs seen in the ED. So that could be a challenge for primary care physicians in learning we have a limited exposure to ECGs. So thank you very much, a very informative lecture. We have a couple of questions here. The first question, if we have a case of SVT, which presents to us in primary care, and the vagal maneuvers did not resolve the issue, and let's say atropine is not available in our primary care center, is there any other medication which we can give other than atropine?
Absolutely. So if you're dealing with an SVT, then ideally you want to give after failed vagal maneuvers, ideally you want to give adenosine. There's also a trial that came out maybe about 5 years ago, and it's been revalidated more recently, where while performing the vagal maneuvers and or specifically while giving the adenosine, then you want to raise the legs. So what you do is you get a good access that's as as central as possible. So at least antecubital fossa, large a line as possible, as wide caliber a line as possible. Have two inputs. So you flush the adenosine, you push the adenosine in one, you flush right away, you raise the arm, and then you have assistance to bring the head down and raise the legs up. That's been shown to increase the success rate of the adenosine with that maneuver. Yes, so just definitely get adenosine. Start with 6 milligrams. If you fail, 12 milligrams. Patient should be on a cardiac monitor, have the 12 lead ECG ready. So if you come back to sinus rhythm, get that 12 lead ECG once it's done. And also be ready to shock the patient in case they decompensate.
Perfect. Thank you very much. Another question we have is with regards to people who have recurrent vasovagal syncope. And if we have like clinically diagnosis of vasovagal syncope, they've done ECGs before in previous syncopal attacks, they were normal. Do we need to repeat the ECG with every new vasovagal, let's say, attack?
So I'm very biased. We see a lot of bad cases. So I'm definitely going to say yes. Now, I'm not sure if that yes applies to your context. If I were in your place, I think I would definitely. If it's another vasovagal attack, I would. The ECG is a very cheap test, and I think and while I like to be very careful about selecting my tests. I definitely would do an ECG for every single patient who presents with syncope. There are extremely well validated clinical syncope rules that are very useful. They do not preclude the performance of an ECG. You still have to do an ECG, but they definitely look at the Canadian syncope risk score. It's one of the most validated syncope risk scores. The San Francisco one, not so much, but look at the Canadian syncope risk score. Again, look it up on MDCalc, apply it to the patient in front of you. It speaks about the specific components of the syncope, and it even details, the determinants of, it helps you try to determine whether or not this is vasovagal, et cetera, clinically based on validated criteria. So try to apply that in your clinical context, and definitely do an ECG.
Perfect. Final question we have, when do we consider T-wave inversion as physiological?
Okay, so there's an excellent slide that I actually didn't put up that I always carry with me, and I actually always look this up. There's specific leads where T-wave inversion, where there's specific leads where the T-waves may be biphasic, and specific leads where the T-waves, and I'm literally looking this up while I'm talking to you. So T-wave should only be inverted in AVR. It may be up or down in the inferior in 3 AVF, V1, and V2. The rest of the leads should be up. So that's a kind of a quick normal T-waves infographic that I always look up. AVR should be down, maybe up or down in 3 and AVF, V1, V2. The rest are up. I'm a huge proponent of memory aids because this is a limited hard drive, and I strongly encourage everybody to use them as well for patient safety and patient care.
Thank you very much, Dr. Mohammed. It was a pleasure having you with us today.
Pleasure was mine.
Thank you for your time.
Thank you.